Hi everyone, we shall be discussing about antepartum hemorrhage. So, antepartum hemorrhage is the bleeding from the female genital tract of a pregnant woman uh, after the after the period of viability, that is usually 28 weeks, and it could be due to several reasons. So, let's classify them into the obstetric cause and gynecological cause. So, talking about the obstetric cause, it could be due to the placenta previa, or it could be due to abruptio placenta, or it could also be due to the vasa previa or circumvallate placenta. Gynecological causes could be due to polyps, or it could be due to cervical carcinoma and other causes. So, while we talk about the placenta previa, let's first discuss about this. Okay, usually the placenta is located would be uh, would be present in the upper segment of the uterus. However, in the case of the placenta previa, due to certain risk factors, okay, which we shall be discussing in a while, the placenta would be present in the lower uterine segment, as a result of which it would be more prone the woman would be more prone for hemorrhage. So, where could the placenta lie? In the lower uterine segment. Let's discuss in terms of the internal os. So, let's consider this is internal os, and if it is present 2 centimeter away, its margin is present 2 centimeter away from the internal os, it's said to be it's said to be the lateral type of placenta previa. Actually, there are four kind. Let me state this one first. It is lateral, second one is marginal, third one is incomplete, and the fourth one is complete. So if the margin of the placenta is located 2 centimeter away from the internal os, then it's said to be lateral kind. And if it just touches the internal os, then it's said to be marginal kind. Whereas in the incomplete and complete kind, the placenta would be covering the internal os partially and completely, respectively. Okay, so the lateral kind and the marginal kind are the minor types of placenta previa, whereas the complete and the incomplete are the major kind of placenta previa. There's another classification as well which says low lying placenta. So in the low lying placenta, it would be present 2 centimeter away from the internal os. Whereas in the case of the placenta previa, as I stated earlier, it could be complete or incomplete type. So there is this classification as well. So what makes a woman prone to having placenta previa? The first one would be the previous history. If she has a previous history of placenta previa, then she is more prone to have placenta previa this time. The second one is multiple gestation. Third one is if there is any sort of mass in the uterus, or if the age of the woman is greater than 30 years. Okay. So, if the woman has a previous history of CS, she becomes more prone to placenta previa. And if there is a history of uterine curettage, also she is more prone to having placenta previa. Now, So how what would be the signs and symptoms of placenta previa? Obviously, we're studying it in the antenatal antepartum hemorrhage. So the symptom would be for vaginal bleeding. So the woman would say, I woke up in a pool of blood in the case of the placenta previa. So what are the signs? Since the woman is bleeding, she will be having pallor. Second, the uterus would be soft and non-tender. Number three, the size of the uterus would be corresponding to the weeks of gestation. Also, there will be a special sign which is known as a stall-worthy sign. So it is present in the posterior placenta previa. And what happens is, if we apply the gentle pressure to the head of the fetus, the heart rate would be dropping, and once we remove the pressure, there would be the prompt recovery of the heart rate, and it is due to the cord compression. So it is present in the posterior placenta previa. Now, how do we manage it? Firstly, we need to understand that do we do the per vaginal examination in the placenta previa? No, we strictly avoid it, because while we navigate through the vagina and we explore for the placenta, the chances for the hemorrhage would be increasing. That's why we are avoiding the per vaginal examination. However, the investigation of the choice is USC abdomen and the transvaginal sonography, because in the transvaginal sonography, we are not letting the probe enter inside the cervix. Okay, so it is just present in the vagina, and it wouldn't be touching the cervix, so it's not reaching to the internal os actually, so we can do the TVS. So that is the investigation of the choice. And how do we manage it? Now, firstly, we will evaluate if to undergo active management or expectant management. Okay, so if the patient is persistently bleeding, okay, if the person is persistently bleeding, or if the patient is hemodynamically unstable, and if the fetal heart rate is dropping, and if there is any sort of anomaly in the USC of the fetus, of course, then we would be going for the active management. And the active management, practically for all the placenta previa cases, we would be going for the cesarean section. However, if the placenta is situated 2 centimeter away from internal os, then vaginal delivery can also be done. Okay, so let's talk about the placenta let's talk about the expectant management. If there is no bleeding, if the person is hemodynamically stable, if the fetus is well, then we would be continuing the pregnancy till 37 weeks. Okay, and during that phase, we will be hospitalizing the patient, and then we would be giving injection betamethasone, 12 mg each, and 2 doses. It's 24 hours apart, and tocolytics would also be given to stop the uterine contraction. And we have, if the mother is Rh negative, then we have to give anti-D immunoglobulin. And we'll have to continue the pregnancy till the 37 weeks, and this is known as a MACIF regimen. Okay, however, if there is any sort of bleeding occurring, then we have to go for the termination of the pregnancy. So that's all about the placenta previa.